for joining today's educational webinar with Cancer Support Community Los Angeles and Cancer Support Community South Bay. I'm Abby Espinosa, the Program Coordinator at UCLA, and I'm honored to welcome you to this week's webinar titled Breast Cancer Therapy 101. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles and Cancer Support Community South Bay are premier nonprofit organizations providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. We'll provide information about our programs and services at the conclusion of this webinar. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org and cscsouthbay.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. You may, however, enter your questions into the Q&A feature found at the bottom of the Zoom window at any time. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we'll get to as many as possible. And to introduce today's speaker, Dr. Peddi specializes in the treatment of breast cancer and strives to provide individualized, compassionate, and cutting-edge care to each one of our patients. After nearly a decade at UCLA, where she was a member of the Medical Oncology faculty, a recipient of the American Society of Clinical Oncology Young Investigator Award for Breast Cancer Research, and lead medical oncology at the Revlon UCLA Breast Cancer Clinic at Ronald Reagan UCLA Medical Center, Dr. Peddi joined the Margie Petersen Breast Center at Providence St. John's Health Center as the Director of Breast Medical Oncology. Dr. Parvin Peddi received her undergraduate degree from Vanderbilt University and her medical degree from the Duke University School of Medicine. She spent a year conducting research at the NIH as a Howard Hughes Scholar before completing her internal medicine training at Washington University in St. Louis, where she served as chief resident and lead co-author of the Washington Manual. It gives me great pleasure to welcome today's speaker, Dr. Parvin Peddi.
Thank you very much. It's a pleasure to be here and give a talk during Breast Cancer Awareness Month. So I'll be just kind of giving a overall big picture overview of breast cancer. And it's a bird's eye view, so it's not going to go into tremendous detail in each type, as we cannot, but hopefully some of each type of breast cancer. And then hopefully I'll have plenty of time at the end for questions and answers. So let me share my screen. All right, so let's start with how, like if someone is diagnosed with breast cancer, what is the first thing that, how it gets diagnosed. So first is usually a mass on screening mammogram. And this is what a mammogram typically looks like. You can have the glands basically that are normal white marks, but then you can see this thing in the middle, this white mass in this patient's mammogram. Typically then this is followed up with an ultrasound to confirm that there is a mass. And this is what an ultrasound looks like of a potential mass. And sometimes patients need MRI as well. So what are the times that MRI is needed? The denser breast is, and the younger a patient is, that usually they go hand in hand. MRI is needed because the breasts are dense and more glandular, and therefore you can have a harder time seeing exactly where the cancer stops and where normal tissue begins. The mammogram we saw earlier was not dense. You could see the mass clearly, but there are lots that this is much less clear. And so when you need to know that exactly before surgery, you do an MRI. And also when the cancer is lobular cancer, and I'll go over that a little bit later on, those cancers are harder to see on mammogram because they're not as mass-like. So MRI can actually see things much more clearly for those patients before you go ahead with surgery. And this is what MRI would look like. I mean, this one is not a subtle one. The one on the, on your right hand of your screen, you can see that big white thing is basically the mass, and the lines are basically the blood vessels, and usually there's more blood flow to a mass, so you can see those being more prominent as well. And MRI, obviously, when you go through the machine, both breasts are imaged at the same time, so it's a good overview of the other breast as well, in case you missed anything on mammogram ultrasound. And at the time of diagnosis, some patients also undergo genetic screening. Now, most breast cancers are not genetic. People are sometimes surprised to hear that when they're diagnosed with breast cancer, and they say, hey, my family doesn't have breast cancer. How come I got this? Actually, only about 5 to 10% of breast cancers are hereditary. Most are not. So we don't genetically test everyone that comes in with breast cancer. People who do get testing are people who are younger, and we define that as less than 50 years old, have 2 breast cancers, like let's say 1 on each side. That would be a red flag to want to do genetic testing. And there are other things too, like any man having breast cancer, if there are relatives that have ovarian cancer, Ashkenazi Jewish descent, and anyone with metastatic breast cancer also needs genetic testing, because there are specific medications that they could potentially use. And the most common genes are the ones I've listed here: BRCA1, BRCA2, and PALB2. So, okay, the breast cancer is diagnosed, whether it's mammogram, ultrasound, or MRI. The next step is like, what is the staging of the breast cancer? So stages 1 to 3 are localized, and stage 4 is metastatic. So stage 1 is basically less than 2 centimeters. Stage 2, it's either more than 2 centimeters or a few lymph nodes are positive. And stage 3 is like even bigger, like typically more than 5 centimeters or so, and 4 or more lymph nodes that are positive. But the main thing is stages 1 to 3, even if it's in the lymph node, your goal as a patient and as your doctors is cure. For stage 4 breast cancer, unfortunately, we're not with our science where we can cure patients, but the goal at that point is control of the breast cancer and prolonging of life, and then hoping for better and better drugs to come along as you go through the treatment. Now, where the cancer starts at, I mentioned before, lobular cancer. So there are mainly 2 places that breast cancer can start in, like in the ducts or in the lobules. Majority start in the ducts of the breast, about 90% of them, and about 10% in the lobules of the breast. And does that make a difference? The only thing that makes a difference is that the lobular cancers you typically do an MRI for, because they can be harder to see on mammogram. But otherwise, whether they start in the ducts or the lobules, it doesn't make much difference in terms of treatment. The treatment is more dictated upon, what does the cancer like for its growth? Which brings me to type of breast cancer. So every breast cancer, we tested for a few genes: estrogen receptor, progesterone receptor, and this thing called HER2. So estrogen and progesterone kind of go hand in hand. They're the female hormones, and normal breast tissue likes estrogen. So a lot of breast cancers, like up to 70%, also use estrogen for their growth. And even if the patients are postmenopausal, they still have some estrogen that can feed the cancer, and therefore these estrogen positive breast cancers. And then this last thing called HER2. So if you look at this normal cell on the left, it has some copies of this protein called HER2 on the surface, the blue crosses that you see. But when you say somebody has a HER2 positive breast cancer, they have many, many more of this molecule. And this is basically a signaling protein, and can drive cell growth and can make the cancers more aggressive. So you need to treat it in the proper way, which is usually chemotherapy with anti-HER2 drugs. So this is critical to know if a patient has HER2 positive breast cancer. So as I mentioned, goals of therapy are stages 1 to 3. You want to go for a cure. Obviously, the percentages that you actually end up curing are different. If stage 3 is a little bit harder, but the majority are still cured. But in the metastatic setting, remission, prolonging of life, and improving symptoms, which for the most majority of patients we are able to do. Now, I'll go breeze through the therapies for breast cancer, and I'll separate them out by the type of the breast cancer. So first, hormone receptor positive breast cancer. So these are the majority of breast cancers, the breast cancers that like hormones for the growth. So for most of these patients, you don't do any treatment before surgery. They just go straight for surgery unless it's very big and you need some kind of treatment to make it smaller for them to be able to have a surgery. But if it's localized, they go for surgery, upfront surgery plus or minus radiation. But everyone is supposed to have some kind of systemic therapy afterwards too. So, whether it was stage 1 or stage 2 or stage 3, we know that these patients still have a risk of distant metastatic disease, meaning a few cells had already escaped before you got to it at the time of surgery. So they need some medication that goes throughout their body to help reduce that chance and increase the cure rate. And that's irrespective of whether they're lymph node positive or not. They still have that risk even if they're lymph node negative. And that's a critical thing that sometimes gets, it's harder for patients to understand. They're like, oh, my lymph node was negative at time of surgery. Why you still say I'm not done? Because that 1 or 2 lymph nodes is not the only place a breast cancer could have gone to, or it could have just gone through it and straight through and still be floating around in the blood. So yes, the risk is lower that there are cancer cells out there, but it's not zero. So, so all of these patients need anti-hormonal therapy, which I'll get to, but who needs also chemo for these patients? So there is a test called Oncotype. Basically, it's like a tumor genomic analysis. So it's as personalized as you can get to try and understand that person's particular breast cancer. And gives a score when you send it to the company. And anything less than 25, if you're postmenopausal, means you don't need chemo, which is great. So in patients who want to do absolutely everything, this gives you the confidence to say that it actually won't give you anything at all, chemo. So it's okay to not do it, and you don't need to feel guilty not doing extra, because chemo was not going to be helpful for this type of breast cancer. Now, in premenopausal women, is a little bit more nuanced. Depends on whether they're lymph node positive or lymph node negative, and depends on the exact number. So, so that requires a discussion with your oncologist to determine whether chemotherapy would help or not, because their risk seems to be higher, premenopausal women. And whether you do chemo or not, when you do the anti-hormonal therapy, sometimes we add additional drugs to it. So this class of drugs called CDK4/6 inhibitors that are pills that basically patients can combine with anti-estrogen therapy, and they can increase the cure rate. And we've had one drug approved in this category for a long time called Verzenio or abemaciclib that can cause GI side effects, but it can be well tolerated. And just recently, last month, we've had approval of a second drug, Kisqali or ribociclib, in this setting for anyone who has lymph node positive breast cancer, and to combine it with anti-hormonal therapy. And even at 3 years is improving survival, and it's going to be even higher when you follow these patients even longer. And then some patients would also benefit from addition of medicines like Zometa, or they belong to a class of drugs called bisphosphonates. And these medicines can, in high-risk patients, reduce the odds that breast cancer goes to the bone. One of the most common places that breast cancer likes to go to is the bone, unfortunately. So we've seen that these medicines, Zometa or things like it, not only do they help strengthen the bone, people with osteoporosis get the same medication, but also seem to have like an anti-cancer properties that help maybe cure, like even cancer cells that are at the beginning of it trying to go to the bone, basically get rid of them. So that's another thing that is a consideration for people who are at risk. You're trying to reduce the odds of them, their cancer going to the bone. So that was hormone receptor positive breast cancer. I didn't talk as much about the hormone therapy itself, but that's basically a pill that's a backbone of the therapy also. And depending on whether they're premenopausal or postmenopausal women, the drug can be different, but about 5 years or so of that medicine is also needed to basically take away estrogen from these as a source of food for these cancer cells that may still be out there. So now about HER2 positive breast cancers. So reminder again, HER2 is this protein that is on the surface of these cancers and makes them more aggressive and more likely to get out of breast, more likely to spread. And so the key to treatment of these cancers is a drug called Herceptin, which is an antibody against HER2. So this is the HER2 molecule. Herceptin goes and binds to it and doesn't let the signaling happen and doesn't let the cells grow. So it needs to be unfortunately combined with chemo. It can't really do it by itself. But what's key to know for these HER2 positive breast cancers is not only are they aggressive, but they respond really well to chemo. So we typically give them chemo even before surgery. If they're like just a few millimeters not, they can go for surgery first. But if they're bigger than that, it's actually essential that your surgeon talks to a medical oncologist and you have the benefit of getting this therapy before surgery. Not only would it give us ideas of whether the chemo was helpful or not and make the surgery easier and a smaller operation, but also it helps let us understand if there are other drugs that we should add later on. So there are drugs such as Kadcyla that I have listed here, that is a smart chemo, a targeted chemo that can be used after surgery. If you did the traditional chemo beforehand and it didn't completely get rid of this cancer, you go for surgery, there's still some left. And then you can do this Kadcyla afterwards that improves the cure rate by more, like about 10%. But if you go for surgery from the beginning and don't do any treatment beforehand, we don't know if the cancer was one that would also benefit from the addition of this drug. So it's critical to see a medical oncologist as well as a surgeon, especially for this type of breast cancer. And then you do the surgery after the chemo. Herceptin versus Kadcyla is continued IV every 3 weeks for the completion of 1 year. And then just a picture of what Kadcyla is a very cool drug. Basically, it's a so-called smart chemo that we're trying to develop for all sorts of types of breast cancer, but so far only have it against HER2. And what it is this purple thing is Herceptin, which I talked about, is the antibody against HER2. And then manually attached to it are these chemo drugs. So these little spikes are so-called payload, we call them. So these are the chemo drugs that are attached to this thing. So then the whole thing gets IV infused, use the antibody to find the Herceptin, the HER2, so which is on the cancer cells. And then this comes in and goes inside the cancer cell. And then only there is the chemo release. And then that cancer cell only gets the chemo, not like everything else that is in the body getting the chemo blindly. So that's why we call it the targeted chemo. And hopefully we'll have many, many more of these in the near future. So it's a cool drug. And the only chance to use it would be to get regular chemo before surgery. And if you still need something in addition, then this drug can hopefully carry the patient and not have any recurrence afterwards. So it was the first smart chemotherapy approved in breast cancer. And 2019 was when it was approved. And rates of breast cancer recurrence were cut in half. So that's a big deal. We also have a second one right now, again, against HER2. It's called Enhertu. Similar concept, just stronger chemo drug. And approved for use since 2019 for HER2 breast cancer that is metastatic. And since 2020 for HER2 low patients. So this is again in the metastatic setting though, that I'm not talking about as much today, but if there are questions at the end, I'm happy to talk about it. This is not in the localized setting. Now, briefly about triple negative breast cancer, and I will actually then be ready to open it up for question and answers. So triple negative breast cancers are cancers that don't have HER2, don't have estrogen or progesterone receptor. And so it's not that they're all the same kind of cancer, but rather they are a group of cancers that have not having other things in common. So they all have in common that they don't have these 3 receptors. But it's really important to understand that they're there actually can be different types of cancers in this basket of triple negative breast cancers. And it's hard at this point for us to know how to separate them out and how to know what to treat each cancer with. And so traditional treatment for these patients is chemotherapy, but more recently, chemotherapy combined with immunotherapy. And so it, just like the HER2 positive breast cancers, is very important to give them chemotherapy before surgery, because for different reasons, not because chemotherapy we know is extremely effective, but because we don't know which chemotherapy is the best one. Because again, we are going blind and we don't know what they're relying on for growth. So you can try chemotherapy before surgery, then go for surgery, and then fine tune. If the chemo did it and everything is gone, wonderful, no more chemo afterwards. But if whatever you chose before didn't completely get rid of the cancer, then try something else after the surgery for macroscopic amount of cancer that could still be out there, and perhaps that also didn't respond to the chemo that you tried. So now, what is this immunotherapy that we combine only so far for this type of breast cancer, not so much for the HER2 positive and estrogen positive, just for the triple negative ones. So immunotherapy is trying to prime the immune system to find the cancer cells. So cancer cells are abnormal, and your immune system is already supposed to be able to find these abnormal cells. However, cancer cells are pretty smart about it, and they have learned how to evade the cancer cells. And one of the ways the immune system, and one of the ways they do that, if you look at the diagram on the left, let's say this is the tumor cell, the gray thing, and it has these proteins on its surface, so-called antigens, that are not normal. Like they shouldn't be expressed, all of them together in a cell, but the tumor cell, because it's crazy and expressing all sorts of different things, has these proteins on the surface. So when the immune system sees this cell, this protein that shouldn't be on the surface, it would recognize it, and then it's supposed to destroy it. But the tumor cell has an additional thing on its surface, this thing called PD-L1, stands for programmed death ligand 1. So this one has a receptor on the immune cell, and it's a I'm okay signal. And so when these two signals kind of interact with one another, then the immune cell is basically neutered, and it basically is turned off and ignores every other signal from the rest of its surface that it gets from the tumor cell. So what are our immunotherapy drugs? They basically break up this connection. So we have drugs that cover the PD-L1, we have drugs that cover this other thing that is on the immune cell. And when you break this connection, then the immune system then can, basically recognize the cancer cell. And the more abnormal a cancer cell is, the more likely it is that the immune system will find it. And triple negative breast cancers seem to be the more abnormal ones, which is why perhaps we've gotten it to work for now for the triple negative breast cancers. So immunotherapy added to chemotherapy for these patients before surgery has really improved their survival. So it's, again, critical if a patient has a new breast cancer, is near breast, to not just see the surgeon, because for this cancer, you want to get your chemo actually started before surgery. And that can be counterintuitive to a lot of patients. They're like, oh, just get this thing out of me. But actually, that thing can be our guide, the thing in the breast, to really understand what chemo is the right one, and to follow it closely and to understand what should be our treatment, because the thing in the breast will come out one or the other. But it's the microscopic cells outside of the breast that are the problem, and you have no way of following them if you take out the main thing in the breast. So this right now is just for patients with triple negative breast cancer before surgery or in the metastatic setting. They can use them as well, especially if you have this protein called PD-L1. So I could go on and on with all sorts of different things, but I want to open it up to question and answers too. So in conclusion, breast cancer can be curable when diagnosed early, and early I even count if it's gone to the lymph node. that's still considered localized and that can still be cured. Metastatic, unfortunately, not at this point. Treatment for these patients involves surgery and also frequently chemotherapy, hormonal therapy, and radiation therapy. Ask him to see a medical oncologist like myself, as well as a surgeon when you're diagnosed with cancer. So it's critical to have the discussion and making sure that the cancer that you have or your loved one has doesn't need any treatment before surgery. Okay, so I will now open it to questions. And reminder, you can put in anything, any questions you have in the Q&A, and I should be able to see them. And I see a few in here. So I'll just get started, but please feel free to put in any questions that come to mind. So first question is, what are your thoughts about cold capping? Does it increase risk in terms of cancer cells in the scalp? Is it safe? And what are my thoughts in general about cold capping? So unfortunately, with our chemos, even so-called light chemos, hair loss is a side effect. So cold capping is basically using cold temperature to vasoconstrict. So the blood vessels that go to the scalp are constricted. So there's less chemo that goes there, not zero, but less. So it can improve the chances of you keeping your hair. There have been enough studies on it for now many years that I feel it's safe. I have not seen any patient have breast cancer come in their scalp because they've used cold caps. And we would have seen it by now. This has been going on, cold capping, for quite a while, and I've been involved in the original trials that got this approved, and haven't seen that. So I don't have a worry about it preventing efficacy or reducing efficacy. It's just important for patients to know that it's not 100%, unfortunately, because it doesn't completely prevent chemo from going to the scalp. So the typical thing is about 60% of patients, give or take, it works. And even in those patients that works, there's some hair loss, but not to the point that they need to wear a wig and looks semi-normal. So I definitely am in support of cold caps. I wish more companies, insurance companies covered it. There's sometimes, a lot of times, cost that is given to the patient and not taken care of by the insurance company. But I don't have any qualms about it preventing efficacy. Next question. It was about adverse side effects from Keytruda. So what is Keytruda? Keytruda is one of the immunotherapy drugs, actually the only one currently approved in breast cancer. There are other ones that are used in other cancers, but not in breast. So I didn't go over the side effects of immunotherapy. So it's definitely easier than chemo. It doesn't cause hair loss, not really nausea or anything like that. But because it's stimulating the immune cell, it can lead to too much activation of the immune cell and therefore to autoimmune issues, meaning your immune cells attacking your normal tissue. Now, these are rare. They're not very common, but the most common of those is affecting the thyroid. So people developing hypothyroidism. That's unfortunately is an irreversible thing when it happens, and that patient will need thyroid replacement from that point on. But it's relatively okay in terms of its management because it's just a little pill that one takes and doesn't cause them any harm otherwise. There are more serious ones that are not as easily fixed, like if the immunotherapy attacks the lungs or the GI tract. For those situations, it's a little bit more involved. Sometimes patients need steroids to calm down the immune system, and they wouldn't be able to get Keytruda anymore going forward. But risk of death or like hospitalization or something much more serious, although it can happen, is much, much less common. Okay, next question. Someone is saying that they have an invasive mucinous carcinoma. Is this lobular? Is its own category? So there are less common types of breast cancer, mucinous, tubular, there are metaplastic, there are other types as well. No, it's not a lobular. It's closer probably to ductal, but it's its own type. But it's supposed to be mucinous. It's supposed to be one of the less aggressive ones, mucinous and tubular ones. Metaplastic is a little bit more aggressive. But just like I said, between the ductal and the lobular, it doesn't matter whether it's mucinous or tubular or whatever. It more matters like what does it rely on for growth, like the estrogen, the progesterone, the HER2, and its stage. So I would ignore that it's called mucinous. It doesn't really matter. All right, next question. How is radiation determined? So I'm a medical oncologist, so I didn't really talk about radiation, but the general principles of radiation are that if someone gets a lumpectomy, they typically should consider radiation for the surrounding area because otherwise the risk of recurrence in the breast is higher. That's number one. Number two is someone who has lymph node positive breast cancer or the cancer was quite big, like let's say more than 5 centimeters or so. Even if they had a mastectomy, they should also still talk to a radiation doctor about addition of radiation because all of those scenarios, the risk of so-called local recurrence, meaning happening, breast cancer coming back in the chest wall, in the lymph nodes, is higher. And if you don't do radiation, but radiation can bring that cost down. I mean, that risk down. Okay, next question. If someone had diagnosed with triple negative breast cancer but did not have immunotherapy prior to surgery, should they ask for immunotherapy at this time? That's a difficult situation. It's not approved in that setting if they didn't get it beforehand. And it's hard to know how long, how much, because are they doing the chemo still? Are they not? And how much chemo? So I would say it's a discussion to be had with your doctor and with your insurance company, honestly, because again, it's not approved in that setting, so they may not even get the okay or the authorization. So this is a critical reason I would say that one should see medical oncologists beforehand, because there are side effects, like I said, from immunotherapy as well. So you want to be sure that it's one that warrants that. So if you already had your surgery, I would say for most patients, I wouldn't add immunotherapy afterwards if we didn't give it before, but it is something to talk to your oncologist about. Okay, with stage 1 or 2 triple negative breast cancer, does chemo kill microscopic cancer cells beyond the breast? Yeah, that's the goal of it. Whenever you get chemo, whether it's stage 1, stage 2, there's triple negative or not, the goal of chemo is for the rest of the body. So absolutely there's risk of metastatic disease otherwise, but even when one does chemo, doesn't mean the risk goes to 0 because you know, the chemo has a certain percentage odds of working. So cure rate on average goes higher, but in a given person, it's hard to know if they are, you know, cured or not. So they just require monitoring. For triple negative breast cancers, I definitely watch them for sure closely for the first 5 years because that's their most dangerous period. But even longer after that because the risk doesn't go to 0 with blood work typically. How long does it take from when the first cancer cell appears in the breast until it shows up on a mammogram? It really depends. You know, there are cancer cells that are, you know, cancers that are very aggressive, like the triple negative breast cancers. So those could be, I guess, months. And there are the slow growing estrogen positive breast cancers that could be even years. So it depends on the biology of the breast cancer itself. Okay, next question. My mother was diagnosed with metastatic breast cancer and started on letrozole and Kisqali. And they're just trying to figure out why the first diagnosis is metastatic because she was completely healthy up until then. I'm sorry, it happens like that. I don't know if your mom was doing mammograms or not, but even if she was, sometimes things are hard to see on mammogram, and you know, they were there and were allowed a chance to spread and you didn't know. Or cancer that is aggressive, even from the beginning, when you see it on mammogram, it is already spread. And cancer that is metastatic doesn't necessarily have symptoms. So unless there's a big spot in the bone that hurts, or unless like is in the liver and is like causing the liver enzymes to go up, things like that, people don't know it, unfortunately, sometimes for a while. So it's not that unusual. It happens. But letrozole and Kisqali are a very good combination. So hopefully it works for a long, long time. And then she has many other options after that. Okay. Let's see. Next question. Can you address side effects from AIs? So AIs are anti-hormonal medicines, aromatase inhibitors. Unfortunately, they're not without side effects. And so the main side effects are like basically postmenopausal symptoms, number one, like hot flashes. There are medicines for that. There are what do you call it? There are herbs over the counter for that. And then joint pain / joint stiffness is another side effect. For that, the more you move, the better. So I would say keep moving, yoga, Pilates, those are helpful. And acupuncture. Acupuncture can actually help with those side effects too. But don't give up. That's the main bottom line. Talk to your oncologist. And there are 3 drugs under the same class, and see if there's another one that would agree with you better. And sometimes that's the case. The one you start out with may not have been the one that agrees with you the best. But sometimes people do have to stop these medications because they're not tolerating it. But I would try your best before you do, because they're very good drugs and they really do reduce the chance of recurrence. So, all right, why targeted chemo only if regular chemo doesn't work? Yeah, I wish that was not the case. The targeted ones we have right now seem to be very targeted, at least the Kadcyla is, to the point that if there's any tumor cells that don't have a ton of HER2, these targeted agents don't work enough. So the study actually was done, and I was part of that study that compared Kadcyla, the targeted agent, versus regular chemo, and we tried that. We tried to see if could beat regular chemo. Obviously, the side effects it would, but also at least be as good in terms of reducing cancer recurrence, and it wasn't. It wasn't as good. So it's basically it wasn't possible to completely eliminate it. So that's the reason. Okay, how do you feel about an oncologist not having done oncotype? So basically, I would say it really depends on the patient and the cancer. Like, not everybody needs oncotype. Like, if it was really small or it was very clear that that patient doesn't need chemo, I wouldn't send oncotype, because it's just one test. And if everything else points to no chemo, I wouldn't want to send a test that could also have an error rate to confuse the picture. So it's not automatic that everybody with a lymph node negative cancer should have oncotype sent. It actually shouldn't be, because it can confuse the picture in the wrong patient. So it's not wrong not to have sent it. Okay, what are the differences between aromatase inhibitors? So there are three aromatase inhibitors under the same class, but we don't know if there's any difference between them. I guess I shouldn't say we don't know. There hasn't been a difference between the 3 of them in terms of efficacy. They have slightly different molecules. But in terms of side effects, we do see that sometimes one agrees with a person versus the other. But in terms of efficacy, they're all the same. So there's not one that is better than the other ones. There's two that are more generic and cheaper. There's one that is more, more expensive and usually a different tier in terms of insurance. But really no difference otherwise. Are bisphosphonate medicines used for metastatic breast cancer, or are they used to prevent metastatic situation? So lots of good questions. So I would say both. So in the metastatic setting, if there is breast cancer in the bone, you know that there's breast cancer in the bone, whether by biopsy or imaging, you are supposed to use bisphosphonates or another drug called Exgeva. But not if there's no bone mets. In the non-metastatic setting, in higher risk patients, and that's not an easy standard definition. I would say that's a discussion between you and your oncologist. But higher risk patients, you can use it to prevent breast cancer recurrence, and doesn't matter if they're estrogen positive or triple negative or HER2 positive. So all of those are fine. So I would say we probably take 2 more questions and then we'll stop. How do you feel about a stage 1 invasive ductal carcinoma premenopausal not doing tamoxifen as a personal choice? Well, it is a personal choice. Just because it's stage 1 doesn't mean the risk of recurrence is low. And I would say more than stage 1, I would need to know, like, more is biology, like how fast it grows on the microscope and so forth. But it's majority of patients would be fine, not taking any medication. Like I would say 70%, maybe 80%, depending on the cancer, would be fine, even without tamoxifen. But that leaves 10 to 20, 30% that may not be. And when I say may not be okay, I mean cancer coming back outside of the breast, metastatic, less than 10 years. So that's a big deal. That's a big deal to me and to most patients. So I try to convince people to try a medicine if they can. If they don't tolerate it, okay, we try and we can stop. But I see a lot of potential for benefit and curing more patients, even in stage 1 breast cancer, in taking an anti-hormonal medication. And then last question, where does breast cancer typically metastasize to first? Typically it's the bone, but there's no rhyme or reason to this. It could go anywhere. It could be liver. I've seen a patient I had recently that unfortunately it was brain and it was nowhere else. So it can happen anywhere. But if you ask statistically, where is the first place? It's on average, it's bone, but can't really discount any other organ. So if any new symptoms happen for a patient, they need to talk to their doctor and make sure that it has nothing to do with the breast cancer and not discount it. So, well, thank you for listening. Anybody else have any questions? Oh yeah, along those lines, I guess one person was asking, what symptoms should we look for? So anything new. So if it's bone, it would be a new bone pain, like head pain or back pain, and so, or a new cough or a new headache or new abdominal pain. I would say anything new out of the ordinary that you're experiencing, give it 2 to 3 weeks. If it goes away, wonderful, has nothing to do with breast cancer. But if it doesn't go away, if it gets worse, talk to your oncologist and make sure it's not concerning to them. They can do your blood work, make sure there's nothing else they need to be doing. You need to have your antenna up, not that you should be worried about it, but hand your antenna up, and so that if there's something going on, we can know about it sooner, right?
Thank you, Dr. Peddi, for your meaningful presentation, and thank you for taking the time to answer all of our questions. We truly appreciate you being here with us today.
My pleasure. Absolutely.
Thank you. And then we have just a closing slide. Kathy, if you will go ahead and share that for us. So thank you to all of our attendees for being here today with us. If you have any questions about CSC Los Angeles or CSC South Bay, please feel free to email CSCLA at info@cancersupportla.org. And if you want to contact Cancer Support Community South Bay, feel free to email Rebecca at cscsouthbay.org. And if you would like to learn more about Cancer Support Community Los Angeles, please feel free to visit our website at cancersupportla.org, and you can scan that QR code. And if you would like to learn more about Cancer Support Community South Bay, you can go ahead and go to cscsouthbay.org and scan that QR code at the bottom as well. Dr. Peddi has graciously agreed to share a copy of her slides, so if you would like a copy of it, please feel free to email us at info@cancersupportla.org or at rebecca@cscsouthbay.org. And thank you again, Dr. Peddi. We truly appreciate you being here today, and thank you to all of our attendees. We hope to see you all at a future webinar.